Thank you, guys. So it won't be news to this crowd probably that untreated mental health issues are a huge problem in this country, especially with the opioid epidemic heating up. And here we have two people who have a very unique perspective on that. One in the correctional setting, actually, which is where a lot of these mental health issues come up, and one integrating behavioral and mental health into the primary care setting. So I guess first I'd like to just get a sense of the scope of the problem. So why don't each of you, Nneka and Christine, just take a look at how do you see untreated mental health issues in your setting? So maybe we could start with you, Nneka.
Yeah, so in the field of corrections, we have about 1.3 million people in the United States that have mental illness that are housed in correctional institutions, such jails and prisons, opposed to about 70,000 that are in public health hospitals. And so you see how the number is clearly much greater in correctional institutions. And not only do we have people coming into our jail, Cook County in particular, with more higher rates of mental illness, but more serious mental illness. We have many individuals coming to us with psychotic disorders, but the majority of people that we're finding have mood disorders.
What about you?
So what we know from epidemiological studies is that only about 50% of people with who could meet criteria for a mental disorder, according to the DSM, actually get any treatment. And among those that do, mostly they're only getting medication management because the place that they access care is usually primary care or the emergency rooms.
That's where most Americans access
mental health care.
Really?
Right. So yeah. So we have a huge issue related to people not getting any treatment, and the ones that do tend to access it through their primary care, and yet we have a mental health system that has a lot of barriers to access, so it's a significant problem. What we also know is that there is a very high degree of correlation between behavioral health issues, subclinical mental illness, as well as mental health conditions that co-occur with a lot of physical health conditions. The reason they get treated in their primary care setting is because they're going in for their migraines, for their IBS, their stomach issues, for their back pain. So people come into primary care for all sorts of reasons, and what we are able to identify when we integrate behavioral health are the mental health correlates of that, and sometimes those are really what's at the crux of their medical problem.
So you're saying that someone might come in with back pain, but really they're experiencing worse back pain because they have depression?
I mean, a number of different conditions have very strong correlates with behavioral health. We know that people with diabetes have a much higher incidence of depression and therefore worse outcomes related to their diabetes. We know that it's true for cardiovascular disease as well. So there's a very strong correlation between particularly chronic medical conditions and behavioral health conditions.
And Nneka, I wanted to ask you, because it's so surprising how many inmates have mental illness. What are some of the things, I mean, I know that it's such a cycle, but what are some of the ways that, let's say, having a traumatic experience as a child living in poverty might then lead to, say, addiction and then eventually to potentially offending?
Absolutely. So, we're in the city of Chicago, and we had one of our most violent years in about 20 years last year. And, you think about what it must be like for a child who can't go outside and play because, their neighborhood is riddled with violence. Or you think about the parent who can't have a family moment at a beach because they're scared of a shooting that just happened this past weekend. Those things, in addition to the lack of education that's occurring, we've closed a number of our schools in Cook County, the lack of mental health agencies. We closed 6 of our 12 community mental health clinics in Chicago in 2012. Those things culminate in traumatic experiences that go untreated. And when you have those experiences and you have very little resources to assist with them, what are you going to do? You're more likely to, engage in criminal behavior, engage in impulsive behaviors, engage in substance use. And so those things put you at risk for interaction with law enforcement. And unfortunately, in our country, we know that law enforcement historically has not been well trained to deal with someone with mental illness. And so that's why we see individuals coming into our custody by the thousands. And, you know, it's unfortunate, but I believe now we're at a point in our history where we know we have to do something different.
And the something different that we have to do, I mean, ideally, you know, we would start to see people kind of talk about these issues at their primary care doctor's office. And I've had the pleasure of seeing integrated family practice in Tennessee. But maybe for folks who aren't that familiar, can you kind of describe what that looks like? What is sort of a integrated system? How does it operate?
Sure. So ideally, when you integrate behavioral health with medicine, you have people who are really practicing side by side. And that the way I like to describe it to patients is the right care by the right provider at the right time. So they're coming to see their primary care doctor, but we're doing very proactive screening to assess for depression, to assess for anxiety, to assess for substance use, and to assess for PTSD and subclinical PTSD. I like to say that, you know, the issues are in the tissues, and so trauma really shows up in people's bodies. It shows up in people's bodies as pain. It shows up in how people access the healthcare system and how they are in relationship to their healthcare providers. And very similar to law enforcement not being trained to deal with this, most medical schools and through residencies, they're not getting a lot of practice and experience with how to deal with this. So when you have behavioral health that's working alongside, you can basically just say, well, I'd like you to also talk to my colleague, right? And you minimize a lot of stigma that is associated with people accessing separate mental health care, and you minimize all of the barriers to access that many of us find, you know, are maybe practitioners, but also are consumers of mental health care. And if anyone's tried to consume mental health care and access that for yourself or family members, you'll recognize that it's not the most user-friendly system, and we don't do a good job of helping people know how to access that in a timely way. And timeliness can make a significant difference in terms of the trajectory of somebody's illness. So you can get people who might not otherwise come to a mental health professional, and I want to speak to the issue around the trauma as well, because I think you can really change people's trajectory when, and hopefully keep them out of your system when you have integrated care that can actually help address what's happening in somebody's body and what's happening in somebody's mind and emotions and how those connect. We have a history of siloing all of that in terms of our data systems, in terms of our treatment, and I think as a system, as a healthcare system, we have to remember that we have a neck that really connects these two, and that these are very integrated in somebody's experience of their health and experience of disease, and we should have healthcare systems that actually that model that as well, that parallel somebody's human experience and not have these in all separate buildings and separate data systems.
Absolutely, and that way, you know, someone doesn't have to say, oh, I have an appointment with my shrink today. They can say, I'm getting my blood pressure medications refilled.
It's the same waiting room, it's the same
Right.
appointment process, everything is essentially, you know, people don't know who you're going to see.
Yeah.
And wouldn't it make sense, because we have so many people with mental illness in correctional institutions, for us to not be siloed and partner with community mental health agencies so that when we're providing care for someone in our custody, we can dialogue with the private or public mental health institution in the community where that individual will be going to relay the medication information, how well they progress throughout treatment, and vice versa when someone is coming into our doors. You know, those are the things that we have to think about differently in society so that we could eliminate those silos and really put people on that better trajectory towards health.
And Nneka, you guys have a really interesting system so that people aren't just released and left to wander around Chicago trying to refill their medications. So can you tell us a little bit about that?
Yes, you know, we have a sheriff in Cook County that is like none other. Sheriff Tom Dart, he is pretty innovative and forward thinking in the sense that he knew very early on that we could not be a part of the community and not invest in the community. And so, you know, for many years and many correctional institutions, even still today, they feel that our duty is done once a person leaves our doors. Well, we started to see those same people matriculating in and out. And so we said we couldn't rely, unfortunately, on our city or local or state government. Instead, we needed to do something on our own. So we have some of our correctional mental health professionals that staffed a closed city mental health clinic because it was in an area where we knew we had an increased number of people coming into our custody. We opened a second one in an area that had no mental health services for at least 20 miles. And when you talk about access, can you imagine someone with a significant mental illness trying to navigate public transportation across gang lines in a city that's riddled with violence? And so we know that those things, were necessary, and we couldn't rely on others to do it. We did it. We have a program where people actually, believe it or not, voluntarily come back to the jail to engage in alumni programs because they are familiar with the services that we provide and are comfortable with those services. Many of those individuals also might need transportation to get to an appointment or even to court. We provide that transportation. And so when you see correctional officers, law enforcement officers, driving someone to a community mental health appointment, it's pretty enlightening. But we as a correctional institution and as a model law enforcement agency needed to do something different.
I'm going to take questions from the audience in a second, but first I just wanted to ask, what are the obstacles to achieving these great models that you guys described? Maybe you can each tell me sort of what has been tried and why do people typically find it, or sometimes find it hard to actually implement this?
Sure. So I think there are several. Certainly the way that we finance healthcare is siloed. So we have carve-out mental health agencies that manage, your mental health treatment different than your physical health treatment. And I think as long as we have that, we are going to have a lot of difficulties because that, again, does not mimic people's experience where mental health issues and physical health issues co-occur. We also have silos within our training and education and workforce development. And so we don't have clinicians who grow up knowing how to work as a team. And I've seen lots of well-intentioned programs that try to move towards integration. Just take somebody who is very traditionally trained in mental health and put them in a primary care setting, and they have a different culture, they speak different language, one has a very, one-on-one patient focus, one has much more of a population focus, and it doesn't work. So having training models that sort of support team-based care, I think, is essential, and then data systems that will communicate with one another and respect patients' privacy, but don't put such a premium on it that it actually creates more potential for medical errors, particularly around things like medication. And just a reflection on what you shared is that for all of the technological advances, which are awesome and wonderful and highlighted here today, it's still, medicine, if you're talking about healthcare, is still a human experience.
Yeah.
And it still really requires that human touch, and that's what people respond to in just listening to your story. So those, I think, are the big obstacles.
And for us, and I'll speak in general for law enforcement, it's very simple. It's just, many people have to think differently about what law enforcement is responsible for. And we are protectors of the community, but that means that we also have to protect the sick as well as the healthy. And, we have to look at training differently, offer crisis intervention training so that our staff, those that are on the street and those that are in the jails and prisons, know how to effectively communicate with someone with mental illness and to help identify it and also de-escalate situations so that they don't result in bringing the person to a jail or a prison.
Yeah. Do we have questions? People are going to run to you. Yeah.
Hello, John Friedman. I'm a physician and healthcare consultant, and this is more of a comment, and Nneka, it's aimed mainly at you. One of my clients has been Heartland Health Outreach, an organization you know, and remarkably, they provide services to homeless and seriously mentally ill folks throughout Chicago. Very, very tough population. And I did a strategic session with them where they were trying to come up with what were the important outcomes of their patients. And it has nothing to do with controlling diabetes. It has nothing to do with whether they're taking their blood pressure medicines. Number two was, do they have a roof over their head most nights? Number one was, can we keep them out of jail?
Yes.
And I almost think from the last presentation, if patient ping instead could be communicating between the PCP and the criminal justice system on being able to manage the additional needs that this population desperately needs.
You know, case management is key, and we work hand in hand with that agency as well as many others. We're actually developing a supportive release center with that agency so that when people are leaving our custody, many of which are homeless, and housing is a key obstacle in the city of Chicago, like, you know, many cities. And so we will give the person a place to lay their head for 24 hours, set them up with a more long-term facility so that they have housing, food on the table, and then job training. We set them up with agencies to offer mental health and medical care. We're hoping those things, and you know, especially with the medical providers, you know, working in partnership with us, will create a situation where people are coming to us with less serious illnesses and far fewer individuals coming to us.
Another question?
Hi, this is Susan Fendel from Mental Health Legal Advisors. I wanted to talk about and ask about the current mantra pushing integration of healthcare. Our clients find that integrating mental health care with the primary care setting is not helpful because of diagnostic overshadowing. You mentioned trauma and pain and the association. Women with psychiatric diagnoses get much later diagnoses of cancer because there is the assumption that the pain is a somatic symptom. So my question is, how do you deal with the fact, and there are numerous studies showing the inferior physical health care once an individual is known to the doctor to have a psychiatric diagnosis, where you have integrated care and the individual does not have any control over who sees their psychiatric information except for therapy notes, which is almost nothing.
Right. So thanks for the question. I think that has a lot to do with training as well. One of the other hats I wear is I teach family physicians of the future, our residents, how to listen to people. And because I think they oftentimes forget that in medical school. And so it's understanding that connection. And one of the things that I do as well is I see myself as an advocate for my patients. And so when you break down those silos of communication and those data silos, I will often advocate for my patients. I have a patient who has a very significant trauma history and had multiple surgeries, had been given PT, physical therapy, a couple of times, would go once, wouldn't go, or just because of the trauma. The idea of being touched just was not okay. So I see myself as an advocate. I was able to reach out with her permission to the physical therapist and say, this is a patient with very severe trauma. And here are some ways that you can work with her, asking permission before touching, allowing her to have maximum control. I've advocated for patients in terms of surgery. So if you see your role as an integrated mental health professional in a really myopic way of just taking care of their mental health needs. So when I say the need for training and for workforce development, it's for that person to also see themselves as part of the whole healthcare team. And it goes way beyond just treating their depression or treating their PTSD. So I think the other thing I want to say is that it's treating people where they feel most comfortable. So some people with very severe and persistent mental illness might see their healthcare home as their community mental health center. So if we can integrate their primary care into that setting and not make them come to someplace else that feels more foreign or uncomfortable for them. So I think it's about integrating in lots of different places. And again, it's like that there's no wrong door, but that we have healthcare teams that can communicate and work together.
Okay, and I have one very quick lightning round question, which is if you could say one sentence to Senate Republicans right about now, or as they're crafting healthcare and thinking about healthcare reform, what would you say?
I would say let's focus on true mental health parity, look at mental illness and treatment thereof, much like we look at medical illness. I know this is a run-on sentence or at best,
It's fine.
but really having a public health campaign to minimize the stigma with mental illness, much like we did for heroin and opioids and AIDS. We really need to get the message out there that this is an illness that deserves public instruction, education early on.
I have a solution,
And
a suggestion. I'm sorry we're out of time, but as a physician who worked in 2 inner-city hospitals in Chicago, I really commend the work you're doing. My name is Edward Dow. I'm an oncologist here in Boston, but I trained in Chicago. And I think the work you're doing is exemplary in the silos breaking down. So here's the solution. What you're describing, these models require manpower. And I think it's important for academia and law enforcement to get together and advocate to the government for more funding for mental health training, psychiatrists, social workers. For a sheriff's deputy to be taking someone to a mental health employment is not a good use of his training or your budget. Classic example, at the end of World War II, the field of psychiatry in this country got a huge boost because the government offered physicians free tuition to go into psychiatry residency because they saw the need with soldiers coming back from the front. Military still has somewhat of a dedication, or at least addressing it may not be perfectly. This is the next war right here on the streets and in the cities and towns. So that's what I would suggest.
Thank you.
What's your sentence?
And I would say that healthcare does not exist without mental health care, physical health care, and community health care.
That's a good one. Let's hope they keep that in mind. Well, thank you so much, Nneka and Christine. Thank you all so much for being here. I appreciate it.
Thank you.